Hello, and thank you for that introduction, Dave. My name is Caitlin O'Connell, and I am the nurse practitioner for the Heterotaxy Program at Boston Children's. Just the screen. Okay, good. I will be speaking to you today about the nurse practitioner role for our program, as well as the multidisciplinary collaborative process that we use. So as the sole NP for our program, I get to practice in a variety of different care settings, and my role shifts depending on where I am meeting a patient. Some of these settings include the maternal fetal care center, where I meet with expectant families whose child is expected to have heterotaxy. On the inpatient side of things, I meet with families in the CICU and the cardiac step-down unit, as well as other units like the newborn nursery. And on the outpatient side of things, I meet patients in clinic, as well as virtually through Zoom visits. My role is varied, and I get to wear many different hats every day, and I'm going to walk through what some of those are in the slides that follow. So the first thing I do when we receive a new referral is to don my detective hat, and that is to see what workup has been done previously. This includes digging into the BCH archives or our records from a child's home institution and looking at all the available data to see that we can understand as much as possible about that child and how heterotaxy has manifested in that child. Our goal is to never repeat any workup that has been done previously, but rather to complement what has been done in order to round out what we consider to be a complete heterotaxy evaluation. Depicted on this slide are the 5 main components that make up what we consider to be a comprehensive heterotaxy evaluation. And this mirrors the heterotaxy management and guidelines paper that Dr. Schillo just showed the citation. Once we've reviewed all of the available data and I get the opportunity to meet with families, I get to don my educator hat. And this education occurs individually with the child and family. And this occurs either virtually or in person, where we review what workup has been done thus far, what evaluations may be available to the family to consider. And then I also take the opportunity, of course, to do a comprehensive heterotaxy education session with families, helping them to understand terms that they may have heard many times before, but may not have fully grasped. So for example, what is intestinal malrotation? How does it develop? And when do we screen patients for this condition? So we walk through all of these topics, usually in the form of a PowerPoint presentation. This is an example of a slide that I use when I'm going through my presentation with families. So this one in particular is talking about the immune system and shows images of polysplenia and asplenia and the different evaluations that we use to look at somebody's main status and their overall immune status. As I'm sure you can imagine, families come to our meeting with a variety of different levels of experience and knowledge about heterotaxy. So I do my best to tailor my time with each family to what they do. Once we have done this initial intake with families and they have decided which evaluations they would like to pursue, I get to wear my coordinator hat. And that means working with our lovely program administrative assistant to coordinate an itinerary for children and their families, which includes referrals to some of the services that you see listed here on the slide, coordinating any testing that is needed. And then after the fact, when children are inpatient, I get to wear this hat again as children are getting ready to transition home, at which point I make sure that all the workup that we intended to do was actually done and that the families have all the information that they need in order to. The air traffic controller hat comes into play for those children and families who are coming to Boston Children's and we're able to do in-person evaluation. So the majority of these children are coming for cardiac catheterization and for cardiac surgical interventions. And we work to integrate their heterotaxy workups into the care that they are already receiving. So some examples of this are for children who are having an immune evaluation with our immunology team. We'll draw the labs that are needed for that evaluation at the time of another blood draw, or perhaps in some cases during a cardiac cath, and there are examples of cath available. Another example would be children who are being evaluated for primary ciliary dyskinesia, doing their nasal ciliary brushings at the time of an anesthetic procedure. So they don't have to incur any discomfort at another time. Then once all this data is gathered, then I work with our heterotaxy team of specialists to come meet with the families, review the data that we have gathered, and provide any recommendations and education about this area. Lastly, I get to wear an ambassador hat. And by this, I mean when I'm able to provide education, of course, to the families, but also on a broader scope, seeking opportunities to speak about heterotaxy and lecture about heterotaxy. This can occur on an informal basis and a more formal basis, not only within the Heart Center, but also within the hospital at large, and of course beyond the hospital. This also refers to our remote second opinion process, where there are children and families who may not be able to travel to Boston for in-person evaluation, but we still review records and help to provide care guidance for those families so that they may pursue their heterotaxy evaluations. Just a moment to talk about our multidisciplinary collaborative process. Dr. Shildlow did mention briefly that we do meet on a monthly basis, our team, and we review children that have moved through the program. This is a great learning experience for all those involved. I go through what all the workups showed, and we really are kind of learning from all of our team members. I also, in addition to this monthly meeting, I meet with our heterotaxy special team members once monthly, where we review incoming patients. So to make sure that we have developed the appropriate heterotaxy care plan for each patient as they move through the program. So both of these ways are really helpful ways to kind of make sure that we're all staying on track and all have the same information. And lastly, I just wanted to share this slide, which is a map of all the home states of the children that have been evaluated by our program since May of 2022 when I joined the program, so up to 29 states and 9 countries, which is really remarkable. Once a child has been evaluated by our program, there's always an open line of communication for anything that they may need in the future, whether it's talking to the PCP about vaccine recommendations or whatever a family needs. So I will turn this over to Dr. Spurgeon in a moment, but just wanted to share that there are many facets to my role. I really enjoy my role as the Heterotaxy Program NP, and it's really a privilege to work with these children and families and play a small role in making sure that they are receiving the best care possible. And with that, I will hand it over to Dr. Spurgeon.
All right, well, thank you very much. I want to start by just saying how grateful I am to Dr. Shildlow and Dr. Ware and Caitlin and the rest of the HRC3 members for their mentorship over the last few years. The goal of my slides here is to show an example of how the multidisciplinary model of care for heterotaxy patients can be adapted to individual institutions while standardizing clinical practices and data collection for eventual collaborative research. So towards the end of my fellowship, I was asking the following questions. What are we doing right now for these patients? What have our outcomes been thus far, and how can we improve those outcomes going forward? And I realized that my first task was just to get help. So that meant reaching out to Dr. Shildlow and others, finding the people who would partner with me locally. And then I needed to correctly identify my local patient population. And then I would be able to determine what changes needed to be made and actually make those changes, track our hopefully improved outcomes going forward. So the first step, finding local partners in various disciplines. This was actually the easiest step for me. I was fortunate to find great partners in key disciplines who either had active research in the related areas or were very interested in participation in caring for these complex patients. Special shout out to Dr. Rivera Sanchez, our local expert on PCD, and Sheridan Waits, one of our talented nurse practitioners and mother of a just delightful little girl who has heterotaxy syndrome. Sheridan is active in the Heterotaxy Connection and presented at the latest meeting. The next and much harder step was to find our patients. There's a general sense that we had a lot of them out there, but there's no specific coding for heterotaxy syndrome in ICD-10. But there are about 277 different diagnosis IDs that I found attached to patients with heterotaxy syndrome just in the chart. And so I was able to combine a direct search of these IDs through Epic with a direct search of echo reports to cast a really broad net and try to pull out and catch every single heterotaxy patient I could find. And this pulled out a little over 1,000 patients, and then kind of a manual curation and chart review of that list eliminated about 75% of them, and that left me with about 19 new heterotaxy diagnoses per year and a kind of a total population of around 274. There were a lot of patients in the initial group that were labeled with suspicion of heterotaxy and a prenatal diagnosis, and then things got copied forwarded in charts, and the inaccurate diagnoses persisted. But Of those patients, the 274 patients with heterotaxy that looked legit, the diagnostic workup was widely varied. Based on the information presented in prior talks, which highlight a need to classify isomerism of multiple organs, I wanted to look at things like bronchial arrangements, splenic anatomy, as well as cardiac anatomy. And only 62 of those patients retrospectively identified could be fully anatomically classified at every level. So there was a clear need to standardize that diagnostic and imaging workup process. So going forward, we decided to make sure that all heterotaxy diagnoses are assigned the same labels on the chart. I made a little flow chart for staff to encourage getting cross-sectional imaging as appropriate. And we're using the ICD-10 codes and diagnosis IDs listed below. And going forward, the terminology we'll be using in the program will be documented according to the International Society for Nomenclature of Heart Disease, which you see on the right side of the screen, with their coding and their ICD-11 codes. And finally, we've planned a series of kind of standardizing counterpoints with our heterotaxy clinic, with PRN visits and e-consultations available at any time. The roadmap caters to patients with single ventricular heart disease. As you may recall, the outcomes being so critically effective in the setting of that disease, but it can be adapted to any patient diagnosed with heterotaxy syndrome. And the key points of our standardization outcome tracking will be focused on vaccination rates, antibiotic prophylaxis, workup of splenic function, neuropsychological evaluation, and improving referral rate to pulmonology for a workup of their PCE risk. So that concludes my portion of the presentation and the presentation in all. And thank you all for your attention.